Hey everybody, and welcome back to another video here at Whiteboard Medicine. Thanks for checking it out. Today is the first video in a series of videos on all things end-tidal capnography or end-tidal CO2. We're going to be ebbing in and out of some of the pathophys behind it, but we're going to have a focus also on waveform analysis. This video is going to be introduction to these concepts. We're going to talk about what end-tidal capnography is, the applications, the pathophysiology behind it, and then we'll get into the introductory capnography waveform with some practice thereafter. For those new to the channel, we are a medical education channel that also dabbles in some kind of medical news. This is our Whiteboard Medicine homepage here. If you go to playlists, we got a whole bunch of playlists organized by topic. This one probably will end up in pulmonology and critical care, we would imagine. So definitely check out the channel if this is something of interest to you. In addition to that, we do have a Patreon page. There's both free membership and paid membership. We put all of our kind of note templates and videos and practice questions on our videos on that Patreon page. We'll link it in the video description. We'd love for y'all to join that too and join kind of our Patreon community on there. So no further ado, quick 30-second break for the introduction. Don't go anywhere though. We'll be right back. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.
All right, thanks for sticking around. So end-tidal capnography. This essentially is a fancy way for the detection of expired carbon dioxide. So end-tidal capnography is a mechanism for us to detect the amount of carbon dioxide someone is expiring, breathing out. You can do this with nasal prongs in the nose. You can do this on an endotracheal tube. You can do this in multiple different ways, but all these devices just detect the carbon dioxide that the patient is breathing out when they expire. If we think about what this means, though, it helps us to understand what exactly is contributing to this. Because it's not as easy as the amount of carbon dioxide in the blood, aka the arterial CO2, does not always equal the end-tidal CO2. Right? Even when these things line up, quote unquote, almost perfectly, there's still usually a difference, a delta of about 5 millimeters of mercury between the end-tidal CO2 and the amount of CO2 in the patient's blood. But many times there's a much bigger gap here because multiple things contribute to the end-tidal CO2 or CO2 being expired out of the body. And to understand that, we're gonna, oh boy, we should have drawn this ahead of time. We're gonna draw a couple things. So the first thing here is a heart, right? That's gonna be the right atrium, right ventricle, left ventricle. We'll also draw a pair of lungs. Let's go with, that's a pair of lungs, right? And then here's kind of trachea, bronchi. And then we'll draw some rudimentary blood flow. So the superior vena cava and the inferior vena cava, IVC, SVC, dumps into the right side of the heart. That blood gets pumped from the right ventricle into the pulmonary blood vessels, then goes to the lungs, and this is deoxygenated blood. So this is kind of high carbon dioxide blood. That then goes through the lungs, where that CO2 gets into the bronchial tree, and then breathed out, expired out. And this is where you detect the end-tidal CO2. That's supposed to be EtCO2. That's really sloppy. I guess we'll erase it and draw it again. The end-tidal CO2. Okay? So it's this whole system that involves the amount of CO2 in the blood, right? So that's kind of the amount of CO2 in the venous system, because that is then delivered to the right side of the heart. But that blood also needs to be pumped to the lungs. It needs to be delivered to the lungs. It then has to be pumped around the lung circulation and diffuse into the windpipe, the bronchioles, right? Because you have all these alveoli. This is an alveolus. It's like a big balloon, and there's thousands upon thousands of these, and they have little blood vessels that run along them. And what happens is that the CO2 in these little blood vessels that are pumped to the lung then dissolves into the alveoli that then goes to the bronchioles, which then again goes into the trachea and is breathed out, expired out. So there's a lot of things that contribute to the amount expired out. For instance, the concentration of carbon dioxide, we actually could even put a PV here, it could be venous carbon dioxide, is related to the end tidal CO2, right? So the amount of carbon dioxide in the venous system. The amount of cardiac output, how good the heart is squeezing, because this right ventricle has to squeeze blood, pump blood to the lungs. So if you have low cardiac output, even if the concentration of carbon dioxide in your blood's high, you're not pumping it to the lungs to be expired. So you're going to have a lower end tidal than your actual carbon dioxide in your blood. The perfusion of the lung, right? So the heart gets the blood to the lung, but then how well that blood is getting around the lung perfusion affects the amount of carbon dioxide you're breathing out. Because I can pump blood to the lung all day long, but if there's a huge blood clot in the lung, a huge pulmonary embolus, so that blood can't get pumped around the lung to all these alveoli, well, your end tidal is not going to be reflective of the concentration of carbon dioxide in the blood. And then ventilation, because at the end of the day, you have to breathe this carbon dioxide out. You have to ventilate it out for it to be detected. So if we were to scroll over the, PV, let's just say the PVCO2, the amount of CO2 in the venous circulation, which is very similar to the amount of CO2 in the arterial circulation. But in a perfect world, this would be about equal to the end tidal CO2. But this is under the assumption that you have normal, NL, normal cardiac output, normal lung perfusion, and a normal ventilatory drive, or a normal ability to ventilate off the CO2. Whereas if any of these are abnormal, that is going to then make this not equal, right? If your cardiac output is actually low and you're not delivering blood to the lungs, your end tidal is going to be lower than your actual amount of dissolved carbon dioxide in your blood. If you don't have normal lung perfusion, you got a big blood clot, your end tidal is going to be lower because you can't get blood with carbon dioxide to the alveoli to expire it out. If you don't have a normal ventilatory drive, you're not ventilating adequately, your end tidal CO2 is going to be lower than the amount of CO2 dissolved in your blood. So this is a much more involved relationship than just simply the carbon dioxide in our blood is what we breathe out, and that's what end tidal detects. Which the good thing about this means that it can give us insight into all these different things, our cardiac output, our lung perfusion, our ventilatory drive, as well as the amount of dissolved carbon dioxide in the blood. So it can give us hints into pathophysiology. And that then gets into applications. There's 4 main applications, although there are certainly additional applications beyond this. One of the big ones, at least in my world, in the emergency department, in the intensive care units, is during cardiopulmonary resuscitation, or CPR, right? Someone is in cardiac arrest. Their heart is not beating, and we are doing chest compressions, and we are trying to restart their heart. Putting an end tidal on the patient is something you should do, because as we mentioned, assuming you have an advanced airway in, they're on an endotracheal tube, right? That means that we're able to ventilate and detect the carbon dioxide. So the other things this is related to now is cardiac output and lung perfusion. Assuming they don't have a big blood clot in the lung, cardiac output is what that is related to primarily. A couple other things too. But if their end tidal CO2 is very low, most people say less than 10 millimeters of mercury, some say 15, because a normal end tidal CO2 is about 35 to 45 millimeters of mercury is normal, NL, normal. So if in cardiac arrest during chest compressions, your end tidal CO2 is less than 10 millimeters of mercury, it could mean that your chest compressions are inadequate because you're not squeezing that heart enough, right? When you're doing chest compressions, you're literally compressing the heart between the sternum and the vertebral column. And if you're not doing that adequately, your cardiac output is going to be low, right? And if your cardiac output is low, as we said, you're not pumping blood to the lungs, so your end tidal is going to be low. In addition to that, if you are doing adequate chest compressions and you're been doing CPR for quite some time and the end tidal remains low, it's a poor prognostic factor that patient is most likely not going to get return of spontaneous circulation. Although again, there's lots kind of to that statement. But cardiopulmonary resuscitation as a target for adequate chest compressions as well as prognostication is one of the indications. Another one is airway assessment. If I intubate a patient, put in a breathing tube, an endotracheal tube, into their trachea, End-tidal CO2 is a way to confirm placement, right? So confirmation of the endotracheal tube, because you should see, as we'll talk about, a nice normal waveform if that endotracheal tube is in the trachea in the right place. Procedural sedation is another one when we give patients kind of sedating medications, do procedures, whether they dislocated their shoulder or their hip and they need to have it reduced. They've broken a bone that's out of alignment and they need to have that reduced. They have a really complex laceration or abscess, or they're unable to be cooperative. Because what end-tidal CO2 will help us understand is how that patient is breathing with their sedating medications. So it's kind of a measure of their respiratory effort while they are sedated. And then identifying pathology, and that gets into what we mentioned over here. Since end-tidal CO2 has so many different variables that affect it, it can help us understand different pathology, right? Pulmonary embolism, obstructive lung disease, heart failure, upper airway obstruction, et cetera, et cetera. And we're going to get into all these things in future videos. So definitely stick around for those, or subscribe and keep an eye out for them if that's something you're interested in. So lots of applications for end-tidal capnography, especially in those in kind of who are sick or undifferentiated or critically ill, or who you're doing procedural sedation on, or what have you. So let's get into the waveform itself. So this is the normal baseline capnographic waveform for end-tidal CO2. And this is what you'll see on the monitor, right? On the monitor, you have a whole bunch of stuff, right? You have respiratory pattern, you have their blood pressure in the corner, you have their heart rate kind of with their QRSs. Wow, that's a really bad QRS. We can't let that stand, but something like that. And then if you have them hooked up to capnography, you'll also have their capnographic waveform going here. Right? Ignore this one. But you see what we mean. So this is what is displayed. This is the waveform displayed. And this is what gives you kind of all the information. This is what you need to understand to be able to pick up on things other people might miss, or pick up on changes in a patient. But to do that, we have to understand normal. And this is normal. This is a normal end-tidal capnography waveform. So what this waveform is showing is it's kind of the end-tidal, ETCO2, end-tidal CO2 over time, right? Y-axis is end-tidal, x-axis is time. And you get this square, and the square repeats over and over again. But what the square is representing is what is important. And we usually divide it into kind of 3 different phases. I suppose 4, because one of them is 0, but 0, 1, 2, and 3. And the way to think about this is what is actually happening. So I want you just to picture someone who's intubated, has an endotracheal tube, and the end-tidal is detecting the expired carbon dioxide into that endotracheal tube when intubation is breathing in and breathing out, so it's constant, right? During that whole respiratory cycle, this CO2 is being tracked in this waveform. And what we see if we just start with inspiration, when we're taking a breath in, the end-tidal is going to be all the way at the bottom here, right? Because you're not breathing out any carbon dioxide, so it's not picking up any end-tidal, it's 0. And this is inhalation. And we'll get into inhalation again, but let's start with the end of inhalation. So this here is I started to inhale, and then I'm inhaling, and right when I'm done inhaling, and I start to expire, that is expiration, that is here, that is this point. And that starts with 1, phase 1. And phase 1 actually first starts at 0, the same end-tidal that is during inhalation. Now, why is that? Well, it's because there's what we call dead space. And dead space are areas that aren't exchanging gas. So if I'm intubated, can we draw a person? This is going to be not good, but let's try. Lips, chin, into windpipe, lungs. That's not great, but not horrible. And we have an endotracheal tube. The endotracheal tube is in our mouth. Let us mute that. Apologies. In our mouth going into the trachea, right? This is our endotracheal tube, our ET tube. And there's a balloon blown up here, so it kind of occludes the trachea. The ET tube pops out the bottom end, and that's what we're breathing through, right? Air goes in, inflates the lungs, and then air goes into the bronchi, bronchioles, bronchi into the trachea, into the endotracheal tube, right? We'll just do it. Actually, let's do it red. That's a better color because it'll be different than the other ones. into the endotracheal tube and is expired out, and then you detect the end tidal CO2 right here. But the first air to be expired out is air that's just sitting in the endotracheal tube and the trachea and the bronchi, right? It's just dead space. It's air that you breathed in that is just not holding any CO2, right? So if I were to let's just pretend the whole system is a pipe, okay? And if I breathe air into the pipe and I breathe that air all the way down to here, this is just air that is not containing any exchange gas, whereas the exchange gases are lower by the alveoli. So then when I breathe out, the first air that this detector here is going to detect is going to be the air that did not exchange gases. After that dead space is when you get to the air that did exchange gases. So anatomic dead space, phase 1, actually has no end tidal because this is just air that was sitting in the airways from when you breathed in, and you breathe out that air first. Now, as you're breathing that air out, apologies, excuse us. As you're breathing that air out, you start to get this upward deflection. The end tidal starts to go up. And then it starts to go up abruptly because this is phase 2, and this is mixed air. It's air that both contains dead space air and air from the alveoli. And that's why it rapidly increases, because you go from air that just was all dead space, it had no gas exchange, it was just sitting in your windpipe, and then the air from the alveoli starts to mix in more and more and more, and this skyrockets up to higher and higher end tidals until you get to phase 3, which is where you kind of get this plateau. And this is all alveolar air. This is all air that came from the lung tissue, the alveoli themselves, that are the true amount of end tidal, because it no longer is containing that dead space air. It's air that is coming from the lungs itself. And the peak of this here is the star, right? This is the end tidal CO2. This is what the monitor's putting up in the corner. Normal, right, is 35 to 45. So phase 1 is when you just start expiring, and you're just expiring the dead space air that was sitting in your endotracheal tube and your trachea that was not exchanging gas. And as you expire more and more of that out, the gas from the alveoli is traveling into the bronchioles, into the bronchi, into the trachea, and you start to get mixed air, right? Gas from the alveoli as well as gas from just the dead space, until it skyrockets upwards. And once it hits this peak and starts to plateau, phase 3, that is when you start to have all alveolar air, and that air reflects the actual end tidal, which is seen in this peak. Now when I'm done expiring and I inhale again, obviously as I'm inhaling, the sensor at the endotracheal tube is now detecting air that I'm breathing in, which this CO2 then drops all the way back down to 0 during inspiration, phase 0, until I expire again, going back into phase 1. Okay? So phase 1 is anatomic dead space at the start of expiration. Phase 2 is when that dead space starts to mix with alveolar air and you get this huge upward increase. Phase 3 is when it starts to plateau off, and that's the alveolar air that then peaks with the actual end tidal, what the monitor will measure, into inhalation again, which is phase 0, which you just started inhaling, so it immediately drops down to 0 for the duration of inspiration until you expire again, going into phase 1, and then obviously going back into the slope over and over again. All right? So hopefully that made sense. It's confusing, but if you really think about what the sensor is seeing, picture yourself as this sensor. If you really picture what that sensor is seeing, at least for us, it starts to kind of make more sense. So we're going to go down to a blank sheet here, and we want you to kind of pause, and you can do this on your own if you want. We're also going to put questions on our Patreon page, so definitely check that out. But I want you to label this whole thing and think about the different phases. So pause it here if you want to do that on your own. If not, we're going to kind of slowly do it with you. So the y-axis is the end tidal CO2 measurement, right? And the x-axis is time. Here we know that this is inhalation, right? It's inhalation where inspiring into our lungs, so the sensor is seeing no end tidal because the air is flowing into the lungs. The air the sensor is seeing is just from the ventilator, from the atmosphere, until you get to phase 1. And phase 1 is when we start to expire. But at first phase 1, the end tidal is still 0 because this is all dead space. This is all just air that was sitting in the trachea that did not exchange gas with the alveoli until you start to get phase 2, which is the mixed air, right? It's air from the alveoli that does have CO2 and air from the dead space, from the trachea, but it's an abrupt, huge increase very quickly until we get to phase 3. And phase 3 is all alveolar air, no longer dead space air. And that's why it plateaus, because that alveolar air has, let's just say the CO2 in the alveolar air is 40. Well, this is what it is for this whole degree of expiration, because then tidal, once you get to alveolar air, even as I'm still breathing out, all that alveolar air has the same amount of carbon dioxide in it. So once I get to phase 3, the carbon dioxide measurement stays the same because it has the same amount of carbon dioxide this whole time I'm expiring alveolar air. And this peak here is what the machine will measure as the end tidal, right? Normal being NL, normal being about 35 to 45 millimeters of mercury, Hg. Until I get into phase 0, which is, yep, you said it, when I start to inspire again, until I go back to phase 1, when I start to expire, and this kind of repeats over and over again as I'm taking breaths. All right, hopefully that made sense. A lot more videos to come on this, getting into more and more complexity. It's a really interesting topic, so definitely subscribe, hit the bell button, stick around. We'll start to update videos as we come out with more end tidal videos. Let us know what thoughts, comments, questions you have down below. Check out the Patreon page for the video notes or practice questions. And either way, stay well, keep learning. We'll see you next time.